Yeah, it's fallen to me to tell you about Health Systems Collaborative. Health systems, what do we mean? Well, we mean all the things that aren't clinical in some sense. So people, organizations, resources, and how they're arranged to deliver care. And collaborative is also worth thinking about a little bit. We're very multidisciplinary, and our work's meaningless if we don't work with others, if we don't work with people doing the job, the people who you'd like to affect. So yeah, collaborative in every sense, and very friendly. I hope to come and find us, come and talk to us. Use us in the same way you would other specialists. If you need a statistician of a particular kind and you think you could do with some advice, where by all means draw on us if you want to consider health systems questions. Yeah, we're a growing group. I joined Mike about 10 years ago, and there were like 2 or 3 of us for many, many years. And in the last few, we've really grown very quickly. I was reminded by Sassy that this slide's missing a few new permanent members of staff, but what we don't show here is about 20, 25 defills as well. So yeah, I suppose in this room at least, a fairly big group, and a fair mix of skills, again reflecting that multidisciplinarity. I'm an engineer, Sassy is a social scientist, Mike's a pediatrician. We've also got a health economist, clinicians, doctors, and Jonathan, who, believe it or not, is a potato expert. There's a story behind that, but he is genuinely a potato expert. And yeah, we look at quite a number of different areas, including diagnostics and technologies and their implementation in different LMIC contexts. So, for example, working with friends in Oku, looking at developing new technologies for intensive care units, but also examining the NEST project, which you heard quite a bit about earlier. Research ethics, most often led by Sassy, but there are others too, and looking at moral distress amongst frontline staff and researchers. And then for a very long time, through Mike's contacts and interests, we've always focused on small and vulnerable newborns. More recently, as I'll discuss here, some work on climate change. Health system resilience and responsiveness is a big theme, as is human resources for health. That's probably the main one, to be honest. And we've got long-term interests in things like task shifting and a new project around physician associates led by Yingxi and Atakrit. So yeah, quite a diverse set of areas of interest. But today I'm going to be talking to you about one of my projects, which is a bit left field for this audience, to be honest. I now realize standing here, but we'll give it a crack anyway. But I like this because I'm an engineer ultimately, and after spending too long doing like kind of, high-minded kind of intellectual things, bolting some solar panels onto roofs makes me feel very happy. And that's what this project involves. So the funders, UK Innovate, which is unusual again for this room, I guess, and they're quite challenging in some respects because they want real change. They want things to happen as a result of this, not just some research papers. And so that's been interesting. And I'm working with a Kenyan company who make very cool solar equipment in Meru County in Kenya. So I've got a question for you. Why aren't all African hospitals using solar energy? It makes sense in Oxford. Like, it makes economic sense in Oxford. In Africa, it's a no-brainer. Why aren't they doing it? Cost, yeah. There's a lot of money on the table. Cost, is that back when it's still worthwhile? It's definitely a consideration. We'll need to come back to it. Let's have a little look first. So everyone probably understands that Kenyan electricity grids are not the best. Most African grids are not the best, to be honest. When they go down, experience blackouts. You can get breakages in the cold chain, loss of vaccines, loss of expensive medications, surgeries are cancelled, services go down, people have to return home. It's an ongoing operational nightmare for places that have this regularly. And it affects, as I say, most countries in Africa, and Kenya isn't the worst of those, but still has significant issues with this. Added to which, the power is not even cheap. Power is quite expensive in many African countries, more than we might pay here. And so you're paying for quite poor provision in general. So again, looking quite like a big need for solar panels, which would provide much higher quality, consistent power, at least through the day. So here are some just outline costs. I know it did very quickly last night, if I'm being honest. But yeah, the total cost of the solar installation we're doing at Merrill Hospital is about £190,000. But the annual savings is about £60,000. It's about £5 a month. And so the payback period is about 3.2 years. It might be a bit less, depends on usage and the number of the types of services that are ongoing in the hospital. But yeah, that seems about right. The expected lifespan is 20 years. That's pessimistic. They might go 25. And over 20 years, that would be £1 million saved. That would pay for 13 medical officers, an extra 13 doctors working at the hospital for that entire period. So again, why aren't African hospitals using solar energy? So it's kind of CapEx, the capital expenditures. They don't have the money up front to buy it, to be able to buy into this solution. If that were the case here, there's banks, there's people that would offer financing. But the problem in this context is trust, and the lack of trust in African institutions to pay back funds over time, and distrust in general means that African organizations tend to pay much more for finance. They get much worse rates. I think they're 3 times worse, actually, is the figure that I've seen knocking around. So yeah, that really limits the ability of these hospitals to get into this space, even though on paper it's in the realm of no-brainer. So yeah, luckily, as I mentioned, the company that I'm working with in Kenya, really innovative, really amazing example of African innovation. And they have created this box they call CPESA, which creates a renewable energy certificate. So this is proof of having produced 1 megawatt hour of sustainable energy. And companies around the world are now buying these certificates to prove that they're supporting the production of green energy. And many big companies have commitments to purchase these RECs in different jurisdictions around the world. And so where some build their own panels, some just buy these RECs and they use that to green their supplies. In the world of AI, power consumption is really going up. So the big buyers of these include Microsoft and Google and so on. But Astonfield have created and patented a method for producing digital versions of these. So previously you needed like a middleman, like a KPMG to come in and prove that you were who you said you were, that the equipment was all set up properly, and to check all the logs and make sure that it was what you say it was. But now the box does it with a cool bit of crypto and some talking to Microsoft Cloud and validation through the inverter. And that means that they can just produce it automatically on site. This is cool because we can use it, I think, to help with this problem of trust. And yeah, this wasn't the idea at the beginning of this project, which is quite nice, actually, that it came out through the research. But yeah, so in this instance, we would have a company that wants to buy these IREX because they've made these commitments to greening their use of energy within their business. And you set the price at a level that means that it would cover the costs over the course of the project, cover the cost of the installation over the course of the project. And then you take that offer, which is from probably a blue chip company, a well-known brand, to a bank. And I've got both a buyer and a bank here, I should say, so this isn't total fantasy land. And ask them to support the installation. So you borrow the money upfront on the basis of this commitment to purchase the RECs in the future. You then install the solar, 1 megawatt hour of energy is produced, the cool new box, the CPESA box, digitally generates the certificate, and the IREC is then returned to the company and retired. And in this way, you have access to upfront finance through the bank, using the commitment to purchase these future certificates as collateral against that. That was probably quite confusing. If you followed it, I'm impressed. But the long and short of it is that we're getting on with it. So this is Meru Hospital, and we're 2 months ahead of schedule on this. Again, Astonfield is really very effective African partner that we're working with. And they've put a new roof on the hospital and solarized it with 228 kilowatts of solar panels. So saving them £5,000 a month, and hopefully we'll be able to generate the data through this to make a much broader case for solarization across Kenya, but then also across Africa. So I've got some cool potential side projects around mapping all of the roofs of all of the hospitals in Africa to see what the potential energy is, and then do the maths on how much money that would cost and see if we can get some partners involved at scale to finance that. Left field project. I appreciate this may just ricochet off of your, this audience, but if it's of interest, please do get in touch. And now, Yingxi to take over. I've got to run. I've got to pick up my kids. But yeah.
I'm Yingxi. I'm a postdoc working in the same research unit, and I'm going to talk a bit on health workforce research, especially medical workforce research in Kenya. And I'd just like to start by saying how important health workforce is. Every health system needs health workers to perform, and whether there's a new drug or a new way of diagnostic or new treatment, there has to be some health workers that's actually doing the hard work. So my presentation will start with a bit of background on the health and medical workforce in Kenya, and I'll introduce a bit of my DPhil project, which I finished last year, and then an overview of a fellowship application continuing some of the work I did during my DPhil that I submitted to NHR earlier this year. So globally, there's a massive shortage of health workers. WHO estimated by 2030 there will be about 80 million shortage, and the shortage is going to be most severe in lower middle income countries, especially sub-Saharan African countries by 2030, which are the countries in red. But I'm not a labor economist. We have labor economists in the room, but health workforce shortage is very complex. This is the health labor market framework that WHO and others have developed. The key message I want to say here is that increasing production of medical doctors or health workers doesn't solve the problem. It's a really complex and dynamic system. There's so many different things you need to consider when there's a shortage of workforce. So in Kenya, obviously there's a shortage of workforce, especially medical doctors. 2018 estimate from Kenya suggests there's about 0.1 to 2 doctors per 1,000 population, which is severely smaller than low middle income country average. And this is even smaller than what WHO aimed for 2013 in the SDG area. But also the other problem on this side is that production of medical doctors is a very lengthy and complex process, as in any country, including in the UK. In Kenya, it includes 6-year training and BBS program, and then 1-year internship, and then you further enter into the workforce before you retrain as a medical specialist, before you re-enter the labor market. And also it's very expensive. Medical training in terms of undergrad training costs about £30,000. So we definitely don't want those money going to waste. However, one challenge we find out is that there are many more doctors being produced or being trained, but not many actually are working in public system. We're interested in public system because that's the majority of where poor population and people in remote area access their service. So in Kenya, the data we had was about 46% of qualified doctors enter the public workforce. This was reported by the Ministry of Health. We also know there are very similar challenges in other countries in Ireland or in the UK, where we know foundation doctors left the NHS after their training. So the question we had was, why was this case? Was it because they are not happy with their life, or is there something else happening? So in my DPhil work, I've conducted, I used a different mix of different methods: surveys, questionnaire, literature-based reviews, qualitative interviews, to really understand what is the experience of being an intern and what is the labor market dynamic and transition of medical workforce at the internship stage. So what is the training context? Where are they training? what's their actual experience in terms of their well-being, their perception of their training environment, how does their training change their, or whether it influence their future career intentions and actual career decisions, and how many of them actually end up in public hospitals and why. So I'm not going to go over all the detail of this, but one aspect of understanding internship training experience, we've interviewed 14 medical doctors and consultants, and also conducted a survey about 350 Kenyan medical officers during the internship. And here was 2 publications from that study, one in NDM Global Health, and the other just earlier this year, using a social science perspective of liminality to examine internship experience. And we find out that many interns, about 60% said they are unable to balance their personal life and their work life, and about 40% think that they have to perform inappropriate tasks during their internship. One of my favorite quotes interviewing the interns was that they have to learn how to do a cesarean section on a YouTube video because their consultant's not around and no one else is there to support them. So this is another quote: being in a hospital where resources are constrained, you realize there's some work you would like to do but can't do in the appropriate time. So the question now is it because they are really unsatisfied with their experience during internship, especially in public hospitals, that they want to leave the public sector immediately as soon as possible? To answer that question, we followed up some of those interns in a questionnaire survey, and also interviewed a few more people. And the results are published in those 2 papers on understanding public service motivation, intention, and decision. And what we find out is that most of those interns are still looking for jobs in the public hospitals, either working as a medical doctor or continuing their specialist training. Very few of them actually wanted to work in private sector or faith-based organizations. However, the challenge is, even though many wanted to work in public hospitals, only 17% were employed in public hospital 1 year after their training, and about 13% were unemployed. And I think it's very obvious no one wants to be unemployed. This is mostly due to job availability. There's just basically no job. And this is another quote from one medical doctor saying, "I just want a job anywhere I can find. I was not able to have the choice." Latest estimate from the WHO across African region is about 25% of qualified healthcare professionals are unemployed at the moment. So we presented those findings together with collaborators and others. This work was largely supported by Cameron Wellcome Trust, and we presented to many important stakeholders in Nairobi last year, including medical schools, including professional associations and councils. And during those conversations, we have agreed that there's a need to improve workforce data and planning. So we know workforce planning is largely lacking in Kenya. Data from my previous DPhil project have pointed to there's unmatched need and supply, or supply and demand of medical doctors. But Kenya is still continuing to further increase medical school training, and a new medical school is established now. So there's really not much national level planning. This will eventually harm the employment of individual doctors, but also considering medical education are subsidized by public finance, we're also wasting a lot of money. But in order to do those good planning, we really need good data, and workforce data in Kenya are largely lacking or inconsistent or fragmented. One key question that we had really simple during my search is how many medical doctors are there in Kenya? These are all data from the same year, from both from the Ministry of Health. The labor market analysis says there's about 12,000 doctors, whereas the HRH strategic review says there are about 4,000 doctors. So it's very big difference. So we really don't know how many doctors there are in Kenya at the moment. I've submitted a global advanced fellowship this year, working with the regulator, the Kenya Medical Practitioner and Dentist Council, to really understand how do we improve medical workforce planning, address the workforce employment experience challenge in Kenya through enhanced data use, intelligence, and governance. So we call this project Medical Workforce Research in Kenya. And I'm not going to go into detail in terms of the research activity I'm going to conduct throughout this fellowship, but we are using a mix of different approach to really understand 3 key questions. One is, what are the data available? A second, how can we actually use a data linkage and survey approach to guide medical workforce planning in Kenya? And the third question is, how do we strengthen governance and build capacity for data-informed workforce planning? To answer the second question, which is we are using one administrative linkage approach. So I don't know if people have heard of the UK Medical Education Database, which is an amazing project done within the UK that we kind of look into. The UK Med data set basically link up individual medical doctor training in Kenya from the stage of applicant to medical school all the way through their training and through their practice. So this is a huge project linking up a lot of existing administrative data, which is really a cost-effective approach for workforce data planning because you don't need to do a separate study or separate survey where you already have a lot of good administrative data available. So we've been looking at how the UK Med data has been being set and talking with the GMC people who was one of the co-hosts or co-lead for the UK Med data set. And we are hoping to leverage some of those experience of building the UK Med data set into workforce planning, medical workforce planning in Kenya, to really explore what are the opportunities for data linkage to map out existing data across the labor market framework and workforce life cycle, including data like the medical council registry, public sector payroll, training institution databases, and likely databases related to medical insurance. We're also going to do some supplementary survey because we recognize administrative data have its own linkage limitation. It can't answer all of our questions. And hopefully with those amazing data set and data product being produced, we're able to address some of the most urgent questions for medical workforce in Kenya, like employment, underemployment, due practice, retention, out-migration, as well as well-being. With that said, I'll pass over probably to Claire to introduce again our MSc program.
Thank you. So because this is a new program, we thought we'd give you a little bit more information in depth about the new Masters in Health Service Improvement and Evaluation. And I must just thank Sebastian Fuller, the course director, for the slides. So, as I said this morning, this has kind of been built on a lot of the short courses and all of the teaching that the Health System Collaborative has been doing over the past few years. And this has culminated in this new Masters that was approved this year and is going to take its first cohort in 2025. And it's taught 1 year in-person Masters. And the idea is to add to the options in the department, but with a complementary course that tries to complement the existing Masters that are already here. So we're trying to fill a very specific gap in a sort of a systems perspective to improving quality and safety of care in health services. And it's really focused on intervention and implementation and evaluation of those interventions. So the type of student that we're looking for really are candidates from wherever in the world, whatever background, but that are wanting to work in health service improvement and in evaluations of complex programs. So we're targeting it at early and mid-career level practitioners, researchers, academics, but people with some evidence of some practical work, whether that's an internship or employment, so that we can build on that and build on the experiences that they've had to produce graduates that can go out and work in health service improvement. Just to give you an idea of what we're trying to get people to learn by the end of this, we want them to be able to identify and understand the context and really understand where they can target areas for improvement and to intervene on. And then we want them to be able to take theories, frameworks, draw from the literature to be able to design really robust interventions and programs to improve the problems that they've identified in that context. And then take that and design plans to evaluate it in a really robust, nuanced way. Turn all of that into a sort of improvement and evaluation plan, and then communicate that and the findings. So as I mentioned this morning, there's sort of 6 core modules that build on each other over the year, with some optional sessions in the Trinity term and then some practical sort of support sessions in the long vacation while they're doing their dissertations. So I'll give you a little bit more information about each of these. So it starts with the foundational modules, which are quite common to many global health masters. So we start with health systems foundations. So what is a health system? And kind of try and embed that systems thinking right from the get-go. so that they're looking at all of these problems from that perspective. Next is this toolbox of methods. So epidemiology, quantitative skills, qualitative research skills, economic cost evaluations, all of those tools that they'll need to be able to go and identify the problems, diagnose the system, explore the context, but also evaluate whatever interventions they develop. So the three modules that are sort of the core of why this Masters is called the Health Service Improvement and Evaluation Masters are these three, and they kind of build on each other, starting with an investigating the context module, which is really about understanding quality and patient safety and what we're trying to actually change in the system, as well as understanding the context in which all of this is going to take place. Then building on that is a module that's very focused on intervention and implementation. So understanding what the issue is in module 3, and then finding a way to use theory, use experience, use other research to design an intervention to solve the problem that they've identified, and then articulate how they think that's going to work, say, for example, in the theory of change, and then plan how they're going to implement it, taking into consideration all the sort of change management, project management components to make sure that that good idea actually gets taken up in practice. And then lastly is to actually evaluate it. So we'll give them the principles of evaluation, as well as a smorgasbord of options of ways that you can evaluate a complex intervention, as well as some of the practicalities around, you know, what funders need, what are the threats to validity that you might encounter, the funding sort of issues with evaluations. And underlying all of these modules is this module 6, which is a cross-cutting module of core skills. So a lot of things around teamwork and how to work in a team, as well as how to lead a team. Then the communication skills, the ethics, and that's of practice in a global health environment, as well as global health research ethics. And then the academic skills, sort of stakeholder engagement and project management skills. Then in Trinity, they'll have the opportunity to attend some optional skills sessions that will help them specialize a little bit. So whatever dissertation they've chosen to do, they can get a little bit more support to focus on their specific topic. And then in the long vacation, some writing workshops to help them write this up. But also, for example, we're going to have a student conference where they'll have an opportunity to have the experience of having presented, as well as organize something at that scale. And well, the assessment for the foundational modules is pretty standard, but how we're going to assess these sort of module 3, 4, 5, those core health service improvement and evaluation modules, is through a big team project. So working in a team, as you would in research or in practice, they're going to be given a problem in a specific context, and they're going to have to fully understand it, and then design and articulate an intervention to address it, and then design the implementation plan and the evaluation plan. And so that is going to be a huge component of their Mike Michaelmas and Hillary. And there are a couple of individual assignments around that so that they can be extended in different ways. But the idea is to scaffold. So you've got them learning to do this in a team with peer support and a team tutor. So each team will have a tutor that will guide them through this process. And then they can go and do it on their own, sort of working more independently in the dissertation, which will take the form of a grant, a sort of mock funding proposal. And the idea of that is that then they've got experience having written a full funding proposal, and they've got something that could potentially turn into a DPhil or future work after the master's. So what we're really trying to do is equip these students with these very practical skills to improve quality and safety in health services in whatever context they're going to be working in, and to be able to implement programs and evaluate them in a really nuanced and robust way, so that we can create people who can go out into the world and make good decisions and good sort of impact on the world, whether they're doing it in industry or if they're doing it as future researchers. So we're advertising like crazy because we need people to apply by the December deadline so they're eligible for scholarships. So if you know anyone who is interested in something like this, please do reach out to us or share the information on this, and we're more than happy to answer any questions.